Question here for our panelist is that what common mistakes do students make early in clerkships and how can they avoid them?
Dr. Salavu unmuted himself, so I feel like there's something you want to jump
Oh,
into.
absolutely. Well, it's a process. So I maybe Dr. Jacobson, if she wanted to talk about the medical school side of things, that is actually aligning the electives and then the clerkships, and then I can talk about the experience when the clerks actually come in. That will be a nice transition. But I can talk about mine first. That is when they are actually in the clerkship and when the clerks come into medicine or another department, how to be very successful. So one of the things that when the students come into medicine, of course, you're very excited. You know, it may be your first clerkship, it may be a subsequent clerkship. If it's the first clerkship, most people get very, very excited. They want to do more. Um, and more is not necessarily better. So I have a session with them, usually the first week or the second week, but I try to do that as early as I can based on the schedule. And I tell them about this same topic, how to be successful. The first one is, you come in, you want to see a lot of patients, but how are you supposed to read if you have a lot of patients? How are you supposed to read? How are you supposed to um, see 4 patients, 5 patients, and then be able to, let's say each patient has a differential diagnosis of, let's say, 3, 4. And then so 4 times 5, 20 different things you're going to read for that particular day. And then tomorrow you're going to have another set, or maybe in 4 or 5 days time, your team is readmitting and you have to get another set of, 20 different topics to read. It's too much. You'll never be able to catch up. Plus, you don't really have the time because you're running around trying to, help the intern or resident do all the various things that they need to do to move the patient to a more healthy state. And that requires a lot of stuff. You have to actually physically do things to make the patient better. So you put that along with trying to read 20 topics is really not possible. And be able to learn and then prepare for the shelf. Because at the end of the day, after your 1 month of clerkship, we expect all the clerks to write the shelf exam and be able to score in the 90s so that they can all get honors and get out, of the elective. So if you're not getting honors, it means that something really didn't go right. And one of them is that you are just carrying a heavy patient load. So that is number one thing. It's a big, big mistake to come with that level of enthusiasm because you want to learn medicine. So fewer is better. So that's number one. Number two is quality, right? So clerks come in and then you take patients because you're all excited, especially those who have, if internal medicine is the first rotation, they get very, very excited. And so they just take any patient. But that's a big mistake. You cannot just take any patient, right? Because for the purpose of the clerkship, it has to be a patient coming through the emergency room with a brand new admission diagnosis. That is the patient we want the clerks to take, right? So it's not any patient, just to have your 3 patients. That's a big mistake. It is if you have to wait for 1 or 2 days for your team to get into cycle for the admission cycle to happen, that is fine. You inherit your brand new patient, and then you can learn from when the symptoms the patient came with the symptoms, so that you know about the symptoms and the progression of those symptoms up until the intervention, the diagnosis, the intervention, and how those symptoms actually got better over time. So you get the chance to actually understand the entire spectrum of disease presentation with symptoms and symptoms going away. So that is so the second part is is saying that not every patient is truly all patients are learning patients. There's no question around that. But the one that you will benefit the most is the one that are truly coming in with fresh diagnosis. So you have to pay attention to that so that you don't carry too many uh, existing patients. So, but it's a balance, right? So maybe let's say for internal medicine, we have high volume. In some of the specialties, they don't have enough volume to say that there are new admissions, and you can have every single patient be a new admission. In that context, yes, you don't just have new admissions enough to be able to do what I'm telling you, and the opportunity is not there for you to do that. So it's okay to have the existing patients, and then you learn as much as you can from those patients. But where the opportunity exists, it's actually better to have more of the new patients compared to the existing patients. And the third thing is the number of I sort of addressed that in the beginning. That's the number itself, in terms of the enthusiasm is so high that you want to carry your 4 or 5 patients, but the number should actually be 1 or 2, at the most 3 patients, at the very, very most. And if you were at the most 3 patients, then maybe one existing patient and then 2 follow-up patients would be like the perfect mix. That would be a perfect mix. You have one that has sort of been worked up, things are happening. Then you have 2 that are just fresh coming in. And then you have the chance to then, actually interview them, examine them for fresh symptoms. You can hear the routes in the rhonchi or the, third heart sound or some abdominal findings. That is the best chance to do that before treatment actually begins, so that you can confirm all the theory that you learn in classroom. So those are the 3 basic things that I typically talk about. Don't make a mistake on those ones. So let me summarize again. Number 1 is don't think that carrying a large volume of patient helps you, because you really need time to read. So, and that is because each patient typically has like 4 or 5 diagnoses. So you don't want to be reading on 20 different differentials. And the whole idea of clerkship is reading, right? You want to see and read. So if you are not reading and you are just seeing, you are not completing the clerkship. The second thing I mentioned was the quality, right? So where the opportunity exists, you want to focus more on the new admissions, because those new admissions will tell you the entire story, from disease presentation to intervention and recovery. You get all the spectrum. And the last piece is really focused on the number. The number is really between 2 and 3. 3, if you have the chance to have 3, then 2 should be the new patients, and then maybe 1 being existing. Those are things that if you are following those basic principles, you should enjoy your clerkships very well.
That was great, Dr. Salfa. There was so many nuggets. I mean, there's so many things I can share, but just I know there's a lot to discuss tonight. One thing I would say is somewhat attitudinal, and it's really the attitude towards feedback. I think a common mistake that just we're humans, and when people give you feedback that sometimes feels great and sometimes doesn't feel so great, it's very natural to become defensive or explain it away, or engage in that kind of conversation rather than really reflect and consider the feedback and how it's actually an opportunity to grow, how it means that your mentor really actually cares about you. It's the way that we as mentors show our interest in your growth is by spending the time observing you and giving you hopefully meaningful feedback. And I think it's a huge mistake for students to resist it or not to see it in the way that it's intended, which is out of generosity, really, even if it's not, a feel good moment in your life. That's okay. That's okay, because we're not really here about us. We're really here to help folks. We're really here to grow. I had a student who's now a 3rd-year psychiatry student out in California who said, we're not here to be right, we're here to get it right. We're all here, always improving, always striving, always aspirational. So it doesn't matter if you're not right in the moment. And it doesn't even matter for your grade, because when we grade you, what we're looking for is people who are growing, people who are looking for those growth opportunities and have an attitude and a growth mindset, and a humility. So I think, if I were to focus on one thing that is so critical for you to succeed in clerkship, I would say seek feedback. Ask for it, because people are busy. And when you get it, appreciate it. Set times for more. Make sure that whatever skill or knowledge or attitude was discussed is then further discussed later. Make the plans. Be a little pushy. It's okay. We love it. We love it. It means that you want to learn. It makes us feel great. It makes us feel that you're taking us seriously. So that if I was to hone in on one thing, although there's so many things I could list, that would be sort of a major takeaway for me.
Yeah, it's just to echo that. I had written down a couple of thoughts. One of them was the feedback. I tell everybody, as Erin knows from my clerkship orientation, I say you don't get what you don't ask for. So if you just ask for how am I doing, you're going to get generic, not helpful feedback. If you say these are the things I'm working on. And how am I doing on working on these skills? And it does require a bit of mindfulness and a real attention paid to kind of where your own growth areas are. So it's not only just asking for what you want and appreciating it, but also working towards kind of identifying your own gaps. But I don't want to dictate exactly what Dr. Jacobson just said. So my other point was going to be I think the idea of thinking that kind of the clinical learning isn't the learning and isn't the studying. You know, a lot of the feedback that I get from my clerkship is that, oh, we don't have enough time to study and there's not enough time to study and the shelf is really hard and the shelf is really hard and it's a medicine shelf and yada, yada. Um, but I think when I sometimes am able to sit down and talk to students, I say, okay, well, like, you are throughout the course of the day, you do have time to read during the day. So how can you actually maximize what you're doing during the day and combine the taking care of the patients with with the learning and the reading? You know, maybe while I'm having an insane clinic day, I can't necessarily do that per se. But I think that most days, if you approach taking care of patients as the same and try to not separate the clinical learning from the studying for the shelf, and you see that actually the two can really go quite hand in hand. I think that that makes all the difference. And it kind of leads into my other point, which is thinking that, you know, you're really going to learn how to do good clinical medicine just by doing test questions. I think you can use the test questions at the end of the day to just test your knowledge on the COPD patient you saw. But if you go in the morning and you pre-round on your COPD patient, and then you read a quick thing in, you know, Step Up to Medicine about COPD and the natural course of COPD and the progression from, as Dr. Salafu was saying, right, the presentation from admission to how they get ready to get discharged. And then you can go home that night and answer a bunch of questions on UWorld about COPD. Like, you're good, you've learned COPD. And so I think you can marry those two much more than I sometimes see students do.
Yeah, thank you so much for sharing that wisdom. Unless our audience has any follow-up question with this, we can move on to Erin's question.
Yes, thank you. I'll just chime in that I found that reading about the patient's conditions that I was managing earlier in the day, doing that in the evening and then doing practice questions on that actually helped me remember things more. It was easier to kind of recall that when I was later taking the shelf. So just putting a plug in there for the advice, Dr. Tripp, that you gave us. It's very good. So the question I have for all of you is just thinking back to students that you've observed, like, what do you think the biggest adjustment is that students face as they move from, you know, doing the preclinical coursework into the clinical rotations?
I sometimes think one of the hardest things is that you're moving, there's two kind of pieces. I think one is moving from a kind of student-centered practice to a patient-centered way of existing, that, you know, your life is now in the service of the patients that you're caring for, and that this is patient-oriented learning, as opposed to when you're in the classroom, it's very oriented to you and what your needs are. And that change is really hard. We sometimes just assume it should be like a light switch, but like it isn't, and that's okay. But I think if you can identify that there's that switch and that switch is really challenging and can be really hard, and embrace it a little bit, I think it makes that transition a little easier. I think along with that, it's this movement from a little bit of like loss of autonomy over your own day to day and what your day looks like and how you control your schedule. Like, one thing I tell students a lot is that as an attending who wears lots of hats, you know, educator and physician and mother, you know, I have to navigate a lot of things, but I have a lot of autonomy over my schedule, over my day to day, over what I do. But I also have like so much responsibility one of the things that's really hard, I think, about being a student is that you may not have all that responsibility, but you have really not a lot of autonomy over what you do day to day and how you spend your days and how your days are structured. And I think that piece is really challenging to navigate because you're entering that phase, and that phase then exists for a little bit through your clinical training until you become, an attending and onwards.
Yeah, I mean, you took the words right out of my mouth. Really, that it's,
Great minds.
exactly. It really is a time where it's just not about you anymore. I mean, it is, of course it is. And as educators, we know it is. But insofar as your journey is about becoming the professional that encompasses the ethic of duty, you have to sort of go through that process of feeling that it's not about you, because it's not. And sometimes students struggle because they know, as Dr. Tripp said, that ultimately the responsibility isn't on, the buck doesn't end with you, right? So you feel if I'm, extraneous, then is it really about duty, or am I, do I need to work on that Friday after Thanksgiving, and, or whatever it is, or on the Saturdays when my team is working, but why shouldn't I be able to go study? Um, because it's part of the journey. It's not, there's no switch. I really like that analogy. There's no switch. And for some folks, it is more of a journey than others. So I think, that sort of, it seems perhaps unnecessary at times. It's necessary in cultivating you into those attitudes, because the buck will end with you pretty shortly. At 3 a.m., when you're the first person at the bedside as even an intern, the buck is with you. And so it's enormous responsibility, and you have to know that it's appropriate responsibility. So I think I really, really appreciate what you say. And I would just add one other point. Something I think is a major adjustment is the balance. That balance between studying, because in the end you are still a student and you have exams and you have shelves to worry about and grades and things that maybe the residents and the faculty don't have on the same regular basis, although we never end with our tests. But they don't have that sort of as ingrained in their promotion, if you will. So it is still important that you study. And I 100% agree that stealing time away from patients is hurting you and your experience. Because when you study around your patients, it's a form of reflection, right? What is reflection? Reflection is when experience becomes wisdom. If you just study quizzes and go through, whatever resources that you've chosen speak to you, those are in a vacuum. When you're studying, thinking about a patient you have a relationship with, that you have empathy for, that you really care about, and then you are attaching that emotion, that sense of duty, that sense of professionalism with your medical knowledge. You are tying that in a way that you will never forget it. You will never forget it. And then it becomes wisdom. It's not just medical knowledge. So that's the other thing I would really say is tying them together and making sure you don't sell yourself short by depriving yourself of these incredible experiences that in many cases are once in a lifetime. I mean, I could tell you I've not been back in the OR other than to take a sample or to be a patient since medical school. And those were privileged experiences. So just, take everything and run with it.
So it's like it's a marathon, not a sprint. One of the things I tell the students when because a real sticking point is on our clerkship we have a half day rounding expectation on the weekends. And I say, like, you don't want it to be that your first 9 days of residency that you may work in a row, which is what it was for me. My first 9 days of residency were in the ICU. You don't ever want to not have had that experience in a space where the buck doesn't stop with you. Like I had worked maybe 6 days in a row until I started residency. So, tack on 3. I was real tired by the end of those 9 days. So the more experience you have, it's like it's training for the marathon that is residency. It's training for the marathon that is the rest of your life. And if you deprive yourself of leaning into that opportunity, you're going to be less prepared. You don't wake up one day and decide you're going to run 26 miles. Maybe someone on here does. I don't know. I don't, because I can't run that much. But if you don't practice that, and you don't flex some of those muscles and that stamina, it's going to just be that much harder in residency when the stakes feel a lot higher, when the stakes feel a lot scarier. Because even though there's a ton of backup in residency, it still feels really scary when, you know, you've got doctor in front of your title and you're putting in the orders and nurses are asking you for things.
Amazing. Thank you both. Do we want to go to the next question with Harija, and perhaps we can direct that towards Dr. Salifu?
No, I wanna say something about the
please.
Yeah.
Go for it.
So another aspect of looking at this question is context. So the context in which you are learning as a student is the science, right? In the preclinical, it's all about the science and the bacteria and the chemistry and all that, those good stuff, right? And then you start the transition now is that now you have to think about a different context. And you get shocked because for the most part, it's not truly science, right? The science guides you, but now you have to fill out forms and you have to do admission notes, and then you have to do, yes, it's a workflow that you have to follow, right? And then you try to, and now you're now applying things, but it's really not like learning the hardcore science any longer. You're basically learning how systems function. And the best clerk is the person who actually understands how that particular system works. How does a patient come to the ED? How can I access the medical record? How can I call for a consultation? How can I request for an X-ray? How can I get the results back? How can I write the admission note? How can I do the discharge summary? If I don't understand what the consulting physician is, how do I get in touch with that person? Look at all these sequence of activities. Where is the science? Right? So it's so when you get the transition is basically the context. The context of the practice is more of the systems-based practice, right? Of what we do as doctors. And then the application then goes along with that system, how the system actually is structured to treat a patient. And I think that could sometimes be overwhelming because you do your science, you're very good at the science, and everything's working out very well. Then all of a sudden, you have to sit down and write a note for an admission, and then you're just writing, and then the patient was, had diarrhea and vomiting and this and that and that, and now you have to put it together. But then when you write the note, you have to put it in a certain place. That's a medical record. You have to know how to actually do it. So it's a lot of, it's a switch. It's a lot of learning to have in order to be able to fit into that systems-based practice model.
Thank you for bringing that up. Yes, the systems aspects as well as the operational aspects. And then, of course, you have the other variable, the actual life patient, too, that comes in there. Certainly are huge adjustments. I'm so glad that you added that. Thank you. Harija, I'll turn it over to you for the next question.
Thank you. Thank you for all the responses. I just remember my first day as a year 3. It was an adjustment. So thank you so much for all the advice. And I have the next question here. What advice do you have for students on how to effectively present patient during rounds?
Okay, I can take this one to start with. So I make jokes with the students a lot. And one of my jokes is that there is a document called the Student Bill of Rights because they don't know that they have rights. So I always remind the students that you have rights, so you have to exercise them. And one of your rights is to actually, be supervised, right? That's your right. Your right to be supervised, and your right to request to be supervised, and no one can say no to you, right? In other words, if you ask the intern, look, the patient just came for admission, I want you to examine the patient with me. No, take the history and physical with me and examine the patient with me. I'm sure you're going to be there. But if you make that request, the intern, resident, or faculty cannot say no. That is the absolute student right. So if you have that in mind, then your attitude changes. In other words, you know that the people around you or teachers around you are going to be responsive to your needs. That's why I make that statement. If you know that this is what needs to happen, then you don't sit back. You have to actually be forward thinking and then actually be more involved because nobody's going to deny you of those rights. And so once you subconsciously you have that in mind, you're going to be doing more things. So which means that you're going to be observing more. You're going to be around when the intern or the resident is taking the history and physical. And if there are things that you need to confirm, you confirm. And if the residents examine the chest, you also examine. If they were RALs, so okay, I also heard RAL. Is that what it is? Yes. There was an S3, yes. Okay, I checked. Is that an S3? Yes, that's an. I put it over here in the left lower sternal border. Yes, I put it. Oh, okay, that's actually an S3 or whatever it is. I palpated the belly. So if you actually know those things and you are around when things are happening, you are verifying your knowledge with whoever is instructing you, it all feeds into your presentations. The comfort, right? The comfort of being able to say things depends on how much you are confident in saying them. And that confidence level is about you being around the people who actually are able to say it comfortably because they've done it several times. So that is the way I always make the point to make the students who come into medicine very, very confident to the extent that they can just know that nobody's going to reject them for anything. Not that they should not hold back. You just move forward and you know that you're going to be supported, which means that you can be around for every single patient interaction because you need to observe, see what the internal resident is doing. You pick it up. Now, this translates into the presentation because now when you are about to do your presentations, everything's already done while you're working with the resident, while you're working with the intern, or maybe even the faculty, the attending. You don't need to go and then write something that's very abstract and present and you're not sure or not sure. That all that has already been rehearsed while you were actually, with the patient. It's already been rehearsed with you already. So when you come now in the morning, you want to, present to your attending. Assume that this was done the way I have described it with the intern and resident, and the next morning now you are going to present to the to the attending. It's so comfortable because you've already done that with the interns and residents. So I think the part of the being effective is actually paying attention and being engaged in the entire process. Don't skip anything. You really have to be engaged in the entire process, and you have to be curious of the entire process, right? If someone say, "Oh, this is JVD," then you really have to do all the measurements. What is the horizontal line, the vertical line? Where is it coming from? And if you do it in that engagement model with the intern, there's no reason why when you're doing a presentation, you don't feel comfortable about doing it. You're going to be very, very comfortable. You're going to actually say more things that maybe the intern didn't remember. So that is the approach I have always, and I meet with all the clerks every single month. So I make sure I make these points before they even start. Um, and I think it's quite effective because you don't want to be doing a presentation that's abstract. No, you just read the record, write things, and then you want to do a presentation. No, you have to be effectively participating in the care of the patient at all levels to be able to make an effective presentation.
Yeah, I would, part of, well, to begin with, I would even take a step back before you present because each field has their own style and their own expectations. So even before you're at that frontline moment, know that it's very appropriate for you to speak to residents and say, hey, what are the expectations? Like, how do people present on medicine, which may be different from OBGYN, which may be different from pediatrics, which may be different if you're in the ICU, as Dr. Tripp mentioned earlier. And they certainly are. There's different cultures, there's different information that's required, there's different things you mention about the patient. So I think, firstly, I would always encourage you to find out in advance what are the expectations, and really pay attention when other folks are presenting and what seems to be the model. I cannot say enough to reinforce what Dr. Sally Fu said, which is know your patients. If you know your patients, if you're engaged with every aspect that you can, when you're presenting, you're just talking. You're just telling folks what you already know. In order to be effective, you do want to think about how you're presenting and just go back to the basics. Just go back to the basics. You have to be telling a history, a physical exam, a assessment and plan, an analysis of the labs, and that's it. It's the same thing you've been doing since day one of medicine. History, physical, labs, assessment, and plan. And if you know that patient, you know them to the moment before rounds, there is nothing challenging. You're just telling a story as you know it. It's okay if your assessment and plan isn't quite in tune with the group. That's completely above board. Nobody will mind. They'll say that's such an interesting way of thinking. That's a great way of thinking. It may not be the way they want, the direction they want to go, but that's where the art of medicine comes in. And that is not a detriment to you. It doesn't make you look like you don't know what you're doing. It just makes you look like you're thinking and you're trying. And that is honors. I mean, to me, that's the best you can do. But knowing your patient is expected, and there's nobody, even on day one, you have the capacity to know your patients, their stories, their labs, their history, their physical exam. Even if the physical exam finding isn't what other people experience, that's fine as long as it's yours. So that's what I would read. Oh, one other thing, don't take shortcuts. Okay. You will experience residents and even faculty who role model these shortcuts. Don't take them. Firstly, as a medical student, you're not in a position yet to know what to cut and trim. Often when people cut and trim, it's not really efficient. It's just, they think they're being efficient because they're cutting out time, but that's not actually effective use of your time. Don't take shortcuts. Don't make that. It's not a way to practice that exudes humility. It's sort of a little bit too big for your britches, if you will. Don't take shortcuts. Take the time. That's how you're going to learn from everything. You learn from normal physical exam, you learn from abnormal, but you'll never know abnormal if you don't do 100 normals. So do a thorough evaluation, a thorough history, a thorough physical exam, and then you'll be the best doctor you can be. Those are my pieces of advice here.
My one quick piece is just to ask for what people expect from you. Everybody, even in internal medicine, you ask 5 different internal medicine attendings, they're all going to tell you they want their presentations done slightly different. I have like a very short attention span. I never liked my presentations to be given to me too long. I have a colleague, he wants everything from soup to nuts. So ask, hey, how do you like your presentations? Because then that's part of life too, is learning how to kind of tailor what you deliver to the people that you're delivering it to, whether that's your attending, your residents, your patients. It's my one piece.
That's excellent.
Thank you so much for this advice. Those are very helpful. I will even add on that, yes, you have to ask what each doctor, how they like their presentation, and practice make it perfect, I will say. So yeah. Now we can go to the next question by Jody.
So I think based on time, just so we have enough time for the small breakouts, we're going to jump into the breakout rooms. So you can see the breakout rooms here. They're going to be 3 different rooms. We'll have the first breakout room on balancing clinical responsibilities with studying with Dr. Salifu. Second breakout room with Dr. Jacobson-Dickman on preparing for the first day of clerkship. And then the third breakout room with Dr. Tripp on maximizing your chances of receiving a strong letter of recommendation.
I just wanted to give some time to Anna Maria. I think she was asking some question to Dr. Salifu. Can you please complete your question so Dr. Salifu can respond?
Yeah. My big question was, there are a lot of places within medicine where you don't have the time to study during the day and read up on cases and things like that, just due to the structure of being in an OR or the way your family preceptor is running his practice. How do you go about that? And how do you get enough studying in without disrupting and completely destroying your own health for it?
Right. That's a very good question. And the best answer I can give you is that this is exactly the reason why we have the clerkship directors. This is exactly the reason why the College of Medicine of every single medical school makes sure that there is someone called clerkship director to balance that, right? To balance the activities of the medical student with the clinical services. So if the examples I give you were in medicine, but if it's another field like the surgery or family medicine where they are more heavy in clinics, the service part of the activity is way more than the education part of the activity. The clerkship director really has to get it very early on. And they will listen to you. They will listen to they will listen to you. That's their job. They will listen to you.
Yeah, and I would add just like a very practical tip, which is nothing very wise, but just we talked about this in our small group. Keep a running list of questions you want to answer. Use the experience of, what your skills you're accruing, what discussions you're part of, what overt teaching you're receiving, to compensate for the literal like computer time, and keep a running list. Nothing with identifiable information about your patients, but just topics that you want to dig deeper into related to your patients. And you should have duty hours. I mean, you have to have limits on your duty hours. That's the LCME requirement. So ultimately, there has to be evenings and weekends available to you. And as Dr. Salfu said, if that's not the case, that is something that needs to be brought up either directly to your clerkship or in your end of clerkship surveys, or to your ombuds person, or to, your associate dean, somebody like me, because those are, limits that are required limits. They're not at the discretion of the medical school, unless they go less than the top level of requirement. So those are my 2 cents to add.
The fundamental principle is that the clerk is there to learn, not to provide a service. So if you stick to that principle and balance a bit, and also you want to be as polite as possible, right? And there are also rules governing your clerkship. So and I like the idea of the evaluations piece, which you are giving feedback. That would benefit other people, right? Because at the end of every clerkship, you have feedback, and then that's actually one of the mechanisms to change the system. But you're not supposed to be overwhelmed with service when you're in a clerkship. With sub-I, sometimes, it's possible to be overwhelmed, and that's understandable because we have to prepare you for the eventual residency. But clerkship is different. The third-year clerkship in medicine is different, or in other subjects is different. You're there to confirm your knowledge, right? You learn a lot of science. Now you want to confirm how that science is utilized practically. And if you want to do that properly, you cannot spend all your time providing service.
Well, and I think just to say come talk to your friendly neighborhood clerkship director about it. But I also think that the better that you're able to learn how to balance all of this in medical school, kind of to what I was saying earlier, all of this is the practice for things moving forward. So the more you can figure out how to balance all the competing demands when you're a clerkship student, and you learn how to navigate that and learn how to solve those problems and learn how to go to people to get advice of, hey, I'm struggling and this is how I'm struggling and how can I struggle less? Once you learn how to ask for the help when you need the help, it's important to do that because you're going to have times in your career where you're going to need that help. And so to me, that's why I think the clerkship year is really so fun, but also really so fundamental in kind of developing who y'all are going to become as clinicians, is learning how to navigate all of the different pieces. I talk about this. I do a session in our kind of our pre-clerkship boot camp that's all about professionalism. And it's not I try to tell students that it's like learning how to be professional is learning like any other skill, and learning how to navigate competing demands and what needs your most attention. Like some days it's my kids that need my number one attention. Sometimes it's my patients that need it. Sometimes it's the students, and learning how to divide my attention and who gets my attention, because it's just a finite amount of attention. It's just a skill.
That's incredible advice. Thank you all. I just want to again thank Dr. Tripp, Dr. Jacobson Dickman, Dr. Salifu. Thank you for joining us today.